The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everybody. Before we start, I wanted to just do a sound check. So if you can hear my voice, if you would just click your hand icon so I know that you can hear me. Great. Got a bunch of hands. Thank you, guys. Okay, we're just going to give it a few more minutes. We have 100 people signed up and we only have about 40 people signed on. So I'm going to give it about 2 minutes to see if we can get most of the people on before we start. So just hang tight. Okay, why don't we go ahead and get started? I'm sure we'll have more people joining as we kind of get through the introductions and the kind of housekeeping matters. Welcome to the Colorado Medical Board Stakeholder Meeting to discuss voluntary confidential treatment and monitoring through the board's designated peer assistance provider. I'm Karen McGovern. I'm the Deputy Division Director of Legal Affairs for the Division of Professions and Occupations, which oversees the medical board. As you might know, all the boards and commissions are housed within the Division of Professions and Occupations. And one of the services that we provide for the board is gathering stakeholder feedback for them so that when they work on policies such as this, rules, things of that nature, we can provide them with your feedback. Joining me today is Paula Martinez. She is the program director for the medical board, and Lori Bratton, who is a manager within the medical board. And they'll be helping me so that I can help facilitate your comments. I want to just kind of start out with a brief overview so we all kind of know where we're going. So I'm going to talk a little bit first about how this platform works to make sure that everyone has the opportunity to engage. I'm going to talk about the other opportunities for early engagement for this policy. And then I'm going to talk a little bit about voluntary confidential treatment and monitoring. What is the current state? Where are we today? Talk about why we're here today. And then I'm going to give you some areas for some targeted feedback. Obviously, for feedback, I want everybody to provide whatever comments or opinions that they wanted to provide on this topic. But I also wanted to delve into some of the questions that the board might be looking at to develop a policy to make sure we're getting them your thoughts and opinions on those issues before they tackle that. And then finally, we'll talk about the next steps in the process. So first, what we have here is kind of what I call the how-tos for early engagement. So to start out with, some of you may be familiar, or I know we have some new people joining, but there are many different types of engaging, many different ways to engage stakeholders. And I think that there's also different timing to engage stakeholders. So those of you who have participated in the rulemaking process know that often we will engage before we write the rules, then we write the rules, then we re-engage to make sure people can look at the written product and then comment on that. And kind of where we are today is what we like to call the early engagement. The medical board is slated to meet on February the 11th, a subcommittee of the medical board, to work on a policy. And so in order to give them all of your feedback and all of your thoughts, we wanted to engage as many stakeholders as possible before the pen hit the paper. So the board knows what you're thinking before they work on drafting this policy. So today, in this sort of platform, everybody will have the opportunity to provide feedback. There is no sign-up list. I've gotten that question. Everybody who's registered and who is on this webinar has the opportunity to provide feedback. So the first way is that when we open up for feedback, you will click your hand icon that says raise your hand. Then we will know that you want to provide feedback. And Paula and Lori will go through and call your name, and they'll unmute your line so that you can provide feedback. Now, I know we have some people who are shy and they don't like to speak on webinars. So you can also enter your written comments in the text box once we start the feedback phase. And then I will go through and read those comments for the group because I want to make sure that they are recorded. So that's our platform for today. We also have another virtual meeting just like this set for next Tuesday, February 9th at 2. It's going to be the exact same format, so people don't need to attend both unless they want to, and if you want to, you're certainly welcome. We're also taking written feedback, so you can submit that to Paula Martinez at state.co.us by Tuesday, February 9th. The reason we have that date on it is because we want to gather all that feedback and give it to the policy subcommittee before they meet so they have a chance to look at it. We've also sent out a survey, and there was a survey sent to everyone who received the notice for this meeting. We sent out a notice for this meeting to all 33,000 licensees of the Colorado Medical Board, all of the medical board's stakeholder groups, people who have signed up for rulemaking, people who have signed up to be on the stakeholder list, people who have already engaged on this regarding this topic. Those notices were sent to everyone. The survey was sent similarly to all those people. And the reason that we have these different mediums, if you will, is that research has shown that people engage different ways. Some people, they don't want to come to the meeting or they don't have time in their schedule. Other people don't feel comfortable doing written feedback. Some people feel comfortable doing a survey. And we want to make sure that when we're talking about 33,000 licensees who definitely have a stake in this policy, we want to make sure that as many people as possible have the opportunity to provide feedback in a medium that is comfortable for them. So I wanted to start out today just to make sure we're all on the same page when we talk about the current state of confidential treatment. So I think it's really important to know that, the medical board has long recognized the importance of licensee privacy, early intervention for health conditions, and its positive impact on patient safety. And this confidential treatment program through a peer assistant provider has been supported by the medical board since the creation of the Peer Assistant Provider Fund. And I don't have the exact date. It was around 2010, 2011. It's been quite some time. This confidential treatment type program has really always been premised on making sure that that the board supports the peer assistant provider's role in confidentially supporting licensees who voluntarily and proactively present to the peer assistance provider with a physical or mental condition before it impacts that provider's practice or results in legal issues. It's also been, really since the inception of sort of this program, if you will, that confidentiality from the board is really contingent on that licensee or applicant's compliance with the peer assistance provider. And that's really sort of how it has worked so far. Now, there's no written board policy that clarifies or defines these parameters. And I'm going to talk about that in a minute, sort of how it's been handled. But the board certainly understands and respects that a written policy would make it very transparent and clear for everyone. It will make it clear and transparent for the licensees, the applicants, consumers who obviously have concerns as well. They have a voice and want to know how this is handled. When I talk about consumers, I'm talking about patients, right? And then also to make sure that regardless of who the peer assistance provider is for the board, that there is something in writing for them to follow. And that it would not change regardless of who the peer assistance provider was. You can see over in this box, there was a 2018 survey of 70 medical boards, and it's done by the Federation of State Medical Boards. And they had a lot of data, but some that I think is important and might help people think about what they want to say or what feedback they want to provide is that out of 70, only 14 require board notification of all peer assistant provider participants. And that's not Colorado, but 14 of them do that. But out of 70, there's only 14. Out of the 70, 65 of the boards require the board notification for participants who don't adhere to the peer assistant provider requirements. And that's where we look over here and we talk about the confidentiality is contingent on compliance. So that's just sort of some information, and I'm hoping will help you frame your comments on what you'd like to see. So when we talk about the current state, we don't have a written policy, but it's important, and I want everyone to sort of know where we sit right now so they know how they want to frame their comments. In the current contract for the peer assistant provider, it says all mental or physical illnesses or conditions qualify for confidential treatment and monitoring with the following exclusions. And you can see them here in red on the slide. Voluntary recipients who self-refer for an illness or condition that has already resulted in substandard medical practice or patient harm, they are not, at this point, are not eligible for the confidential treatment and monitoring. Recipients who self-refer for an illness or condition that has resulted in or contributed to a violation of state or federal criminal law are not eligible. And then there's the caveat that municipal offenses and minor traffic violations that do not involve drugs or alcohol would not render the recipient ineligible. And then last, it's someone who self-refers for an illness or condition that has resulted in or contributed to an adverse action or professional disciplinary action are not eligible. So if you look at those, you can see that it goes right back to what I was saying, was that it's contingent on the health provider, the practitioner, however we want to classify them. And here we can say the physician assistant, or the anesthesiologist assistant. It's contingent on them seeking help through the peer assistant provider before their condition impacts their practice, before it causes them to incur legal, either criminal charges or other legal problems being an adverse action by an employer or a professional disciplinary action. How this works, again, there's no policy, but how this works is that through the peer assistant provider contract, the peer assistant provider is responsible for screening voluntary applicants for eligibility to make sure that none of these exclusions exist, to make sure that they're eligible for the confidential treatment and monitoring. The peer assistant provider is required to notify the applicants or the licensee of the board's reporting requirements and the eligibility when that person presents to be in the confidential program. And then there are monthly meetings, which are called liaison meetings, where a member of the medical board, the program director, and representatives of the peer assistance provider will get together and we'll talk about the participants in a confidential program. It's de-identified so that the members of the board don't know who these people are, just to make sure that they fall within the parameters that I've just set forth. So that's how it currently works. That's where we are today. So why are we here? Well, because the board is revisiting the confidential treatment monitoring program. They want to memorialize what we just talked about, sort of the parameters, and they want to memorialize that through board policy. That way, again, it's transparent. All licensees and applicants know where they stand, what are the requirements, how does it work, that the community understands where we are and how it is and how does it work. They want to gather all of this feedback so they can start drafting that policy and making sure that they hear from everyone. So when you think about the perspective here, we have about 33,000 licensees. We have roughly, if we take out the people who are ordered to the peer assistance provider by the board, depending on the year, we could have 600 to, we could have 1,000, right? But that is the percentage, those are the numbers. So out of 33,000 people, we have, at most 1,000 people that we're talking about with this policy. But because everybody has the opportunity, every licensee has the opportunity to visit their peer assistance program, we want to make sure that we get as much feedback from those 33,000 people, the stakeholders, the consumers, so that when the board writes this policy, they know what people are thinking about. They understand what concerns people, what they want to see, what they think the hangups are, what barriers are they seeing. Those are all very important things for the board to consider when they're working on this, on the policy. So now I want to sort of talk about, and I know that I'm speaking fast because I want to give you all the most time possible so that you can provide feedback. So we talk about targeted feedback, and I think that the questions, I'm going to leave these questions up while you're providing your feedback, but I think these are some of the things that we've heard and things where people either feel very strongly about or people feel like they don't understand. So I think overarchingly is, what should a confidential program through a peer assistance provider look like? What should that look like? What should be the eligibility requirements? Who is eligible? Should the person be required to seek the confidential treatment voluntarily? Should they be somebody who's mandated to go there? Should the request be prior to the impact on practice, or does that matter? Should there be exclusions? If there should, what should they be? Compliance. Should compliance with the recommendations be required? And if so, what do you think compliance looks like? Or conversely, what do you think non-compliance looks like? Limitations. At what point, if any, should the peer assistance provider report non-compliance to the board? Should should the applicant or the licensee know what those limits are before entering the program? And if so, how should we do that? And then how does any of this ensure patient safety? What safeguards should be put in place? Is that important? What are your thoughts about that? And I think that's, again, I want to be clear that everyone's entitled to provide whatever feedback they like. And these are just maybe some thought starters, things that might be helpful to the board as they sort of look at this issue. So at this point, anyone who wants to provide feedback, so everybody on the call, looks like we have about 70 people. If you would like to provide comments, feedback, if you would like to address these questions, if you have your own feedback, if you raise your hand, we'll go through and call on you. I'm not going to put time limits on people, but I do want to make sure that we all recognize there are 70 people in the room, and we want to make sure everybody has the opportunity to provide their feedback. So I'd ask that we're all respectful of that. So let's get started. Paula, if you see any hands, we'll both scroll down. It's a long list, but go ahead and call their names and mute them.
Okay. I'm scrolling.
I see Ned Caland. I'm going to go ahead and unmute his line while you scroll. Ned Caland, your line is unmuted.
Thank you very much. And I want to thank the department for allowing us this opportunity to provide feedback. I was on the medical board for 12 years and president of the board for 7 of those, and worked directly with the leadership of the peer assistance program at the time that we were contracted with them. And I want to speak in favor of the crafting a policy that matches the current approach that is written into the contract for peer review. I think in terms of eligibility requirements, exclusions, compliance, and limitations, I think those are really well covered in the way the current practice is undertaken. I want to state that my experience with that over a 12-year period of time, there was never a single instance where that confidentiality provision resulted in substandard care or harm to a patient. On the other hand, there were lots of physicians who completed their treatment, addressed their issues, and continue to provide safe medical care. And always during that time, Colorado was listed in the top 10 medical licensing boards by the Federation of State Medical Boards. So I think this evidence says that this approach supports more physicians to seek treatment. It takes away the chilling effect and worry about reporting to the board in seeking care on your own. There's no evidence of harm to patients. The protection of the core of the licensing philosophy is no harm to patients. And I think in the face of the unprecedented stress and strain on frontline physicians during the COVID epidemic, there probably is no more important time to really codify this and put it into policy to help this practice continue to provide services to our physicians and top-notch, high-quality medical care to the people of Colorado. And thanks for the opportunity to comment.
Thank you, Dr. Caland.
So next we have Robert L. Seaver.
Okay.
I unmuted him. You are unmuted. Robert, you're unmuted. If you want to speak.
You'll need to unmute yourself on your end, but you're unmuted on our end. Robert Alciver. Okay. We can come back. You can raise your hand again if you want to make a comment. Who do we have next, Paula?
Looking.
While you're looking, I can go ahead and read some things that have come into the question box or chat. We had a few comments by James Borgstead before the webinar started, and I want to make sure that we include those. And I'm just trying to, just give me a minute, pop those questions out so I can read them. Okay, it looks like we have Mr. Allsiever's hand back up. Mr. Allsiever, I'm unmuting your line. Robert Allsiever. Okay, while we wait for Mr. Allsiever, I'm going to go ahead. Okay, let me go ahead and read some of these comments from Dr. Bergstead before we go there. Dr. Borgstead says, requiring a release of information for the CMB at onset of seeking help is a mistake. The CMB Liaison Committee protects participants' confidentiality and allows the CMB to have oversight of participants who are unsafe to practice medicine. The current peer assistance provider has always had participants sign a confidentiality agreement upon entering the program. The wording of your survey was convoluted and confusing, particularly regarding relapse. Relapse does not equal non-compliance with patient health and safety. We have a comment from Christy Powell-Mormon. I believe compliance looks like answering and returning phone calls, emails in a timely manner, responding in a timely manner to requests from the PAP, and complying with testing requirements. Okay, and it looks like Dr. Borgstead would like to speak. It would be James Borgstead. Could you unmute his line, Paula?
Yes.
Can you hear me?
Yes.
Yes, well, I want to thank you very much for this session. This is a great opportunity. I'm speaking with 5 years of past experience as the CMB board president, and I'm also speaking in support of the current contract. You have my written comments and you have the comments that you just read. And I am concerned about two things. One, this chilling effect with the potential change in structure of the confidentiality. And the other thing is whatever the medical board decision is, I think you also need to be mindful of a peer assistance provider that has physicians on the board and has physician experience and expertise. Thank you very much.
Thank you, Dr. Borgstead. Paula, who's next?
We have Jeremy Lazarus.
Okay.
He's on here twice. He's self-muted.
Jeremy Lazarus, if you unmute yourself on your end, you can go ahead and speak. Okay. Let's go to the next person and we'll come back. Jeremy Lazarus, re-raise your hand.
So we have Robert Allsiever again. Let's see.
Okay.
You're unmuted.
You're unmuted. Robert Allsiever, if you'd like to speak, you're gonna have to unmute yourself on your end. If you go onto the control panel, you'll see the microphone and you need to click it so that it shows green. There you are. You're unmuted. Go ahead and speak. So we're not hearing you, Robert Alsever. If you would like to type your comments into the box, I can read them for you. For some reason, we're not able to hear you. Looks like we have Tyler Onstead. And please know that when I'm looking at the list, I have your first and last name. So if I inadvertently call you Ms. or Mr. and you're a doctor, please understand I have no way of knowing that when I look at the list. So Tyler Onstead, you're unmuted.
Hi, can you hear me?
Yes.
Great, wonderful. Thank you so much to the board for holding this very important session. My name is Dr. Tyler Onstead. I am a internal medicine physician at the University of Colorado Hospital, speaking on behalf of both myself as well as the Faculty Senate, of which I'm a member of. The Faculty Senate at the University of Colorado School of Medicine represents more than 4,800 full-time faculty physicians, researchers, and teachers. And we're speaking in support of the current contract with the CPHP. We want to express our profound disappointment at the potential loss of this, as the peer support program is vitally important, particularly to on the point of confidentiality through obtaining services through a peer health agency, requiring providers to sign a waiver to release their medical information, even when they seek help voluntarily, will substantially decrease the number of physicians who seek care. Further, discriminating against a physician or a provider for seeking help is ethically wrong and adds to the stigmatization of mental illness. And finally, we strongly believe that a peer health program should be comprised of our peers in medicine and therefore staffed by board-certified psychiatrists, licensed psychologists, and other doctoral level providers in order to provide peer level support and care. So again, strongly advocate for maintaining the current status of the contract and maintaining the confidentiality. Thank you very much.
Thank you. Really appreciate that. Who's next, Paula?
We have Kristen Hopper.
Okay.
Kristen,
Can you hear me? Can you hear me?
Yeah.
Hi,
Yeah.
I'm Kristen Hopper, the medical director of the Center for Dependency, Addiction, and Recovery at the University of Colorado Health Sciences Center, and also a professor of psychiatry and addiction medicine. And I do want to speak in support in general of having confidentiality available to people seeking treatment from the perspective of someone who treats physicians and trainee physicians. It's very helpful if they can voluntarily seek help. Working with folks who are sometimes ambivalent about whether they're going to present themselves. This concern about confidentiality is a major barrier, and I think would really create barriers to helping people work with a peer assistance provider. Thank you. And thank you for holding this session.
Thank you. I'm going to go ahead and read some of the comments in the comments box while Paula, you look for more hands. So Christy Mormon, who is, and I'm sorry, yes, Christy Powell Mormon. She says, as far as exclusions, I don't think anyone who is voluntarily reporting should be excluded. Jean Martin from Copic says, our policy holders have raised concerns about the survey questions, particularly around the exclusions. Copic has provided communications with the board and shares the board's goal of patient safety. Will stakeholders be able to provide feedback on the board's policy before it's finalized? And we will get to next steps at the end of this webinar, and we'll talk about where we go from here, and I'll explain what will happen as the board drafts its policy. Christy Powell-Mormon says, I also strongly agree that relapse does not mean non-compliance, and those who relapse, should not be excluded from the program or reported to the board so long as they continue to comply and no harm was done. I am also supportive of our current peer assistant provider. I treated many physicians through CPHP program. I think that the current system is exactly right. I think making this more granular will not be helpful. Having the liaison process, process, and I'm sorry, the type in my box is very tiny. So, having the liaison process allows for judgment to be used in circumstances where there's a question about confidentiality. As the former president of the AMA Colorado has been seen as a leader in the country, as a current member of AMA's Council on Ethical and Judicial Affairs, I am doubly convinced of the need for the ability to have judgment in these decisions and to keep the current policies in place. And that's Jeremy Lazarus, Dr. Jeremy Lazarus. Okay, Paula, who else do we have?
We have Brian Hines.
Okay.
Yes.
Can you hear me?
Yes.
Okay. Well, thank you for having me. My name is Brian Hines. I'm a family physician in Pueblo, Colorado, actually, and I guess I'm calling from the perspective of somebody that's been through the whole process, actually, because I called for help at CPHP in 2005 when I found myself in a very bad place in my life. I was suffering from mental illness, depression, anxiety, as well as alcoholism and drug addiction. And at the time, I found a place where I could call that received me with love unconditionally and accepted me, and helped me actually just even confess that I had this issue. And that was the first part of me getting well. And I just found that the confidentiality and all the services that they provided me were just amazing. And today I have a successful family practice. I have completed all the things that I had to jump through, all the hoops that I had to jump through, and I am no longer necessarily required to go there. I actually do it voluntarily. I embrace that. I love to have an accountability partner. I've been completely sober for 15 years now, and this by the grace of God. And I wear that with a badge of honor. I mean, even been in the club with all the physicians and that, which is a great badge of honor. But being sober now in my life is probably one of the greatest things I've ever, been able to accomplish. So without CPHP, I wouldn't be there. And so I support the system that's in place now. I've got a beautiful life. I've been married for 30 years. I have 4 children. My son is an anesthesiologist at the University of Texas, San Antonio. And all of them went through this with me as well. So they're well aware, and they're well, educated on, how a physician gets help and how the process is, and, and able to, get back on track. And so I'm just grateful. I'm grateful for CPHP. They're my heroes, you might say. My wife and my kids feel the same way. And so I just wanted to speak out in support of them. I really just overwhelmed with how they helped me, and I'm forever grateful, because I get to practice in my gifts and talents, no different from anybody else. I just had this disease that held me back, and it put me in a place where I could have been dangerous, right? And they helped me, get through that, helped me get practice safely, and they've helped me, maintain accountability since 2005, and today I'm, happier and more joyful, and than I've ever been in my life. I love, I'm grateful, you know, what a gift to be a doctor. You know, I almost lost that, you know, in my process, but, you know, by the grace of God, but through CPHP, I was able to continue. So I just wanted to just, you know, comment in support of their program, and I support them 100% and just appreciate it. So thank you so much.
Thank you. We really appreciate your feedback and appreciate you sharing your story. Next, I'm going to run down here, Paula, to Connie Price. It looks like her hand has been up for a while. I'm not sure if it was from when I was doing sound check or if she has something to add.
No, I just have something to add. Can you hear me?
Yes.
Great. So my name is Connie Price. I'm the Chief Medical Officer at Denver Health and Hospital. I've also been a member of the medical staff at Denver Health for the past 19 years. And I am speaking on behalf of me in my role as Chief Medical Officer in the administration of Denver Health, that on behalf of Safe Harbor and confidentiality, and the need to preserve that confidentiality for our providers or physicians who seek care for these types of issues. There are good data showing that the lack of safe harbor or the lack of confidentiality will discourage physicians and others to seek treatment. And if that happens, my fear is that it is not like these people would just leave their careers, their jobs. They would try to deal with this on their own. They would continue in their role, continue to practice, continue to suffer, and potentially do harm. With these protections, they're more likely to seek the care they need, to remove themselves from the environment should that be necessary during their during their time of seeking treatment. So for this reason, we very much support keeping safe harbor and confidentiality intact, and to the greatest extent possible to encourage all our physicians to get the help they need when they are in these situations. And no time more than now is this necessary after everything we've been through with COVID. Thank you.
Thank you. I really appreciate it.
We have Monica Patton next.
Okay. Monica, your line's been unmuted.
Can you hear me?
Yes.
Wonderful. Thank you for the opportunity today to speak on behalf of medical students in the state of Colorado. My name is Monica Patton. I'm a second-year medical student at the University of Colorado, as well as a co-chair and board member of the medical student section of the Colorado Medical Society. I know that I'm speaking to many of a group of individuals who, with a shared understanding of the incredible workload placed on medical students during their preclinical and clinical training. For me, the ability to access confidential mental health resources has been paramount to my success throughout medical school. There's so much stigma surrounding mental health that continues to pervade the medical community and society as a whole, and knowing that I'm able to seek those resources without fear of the future consequences it may have on my career is one of the reasons I sought care in the first place. I'm not alone in this feeling, and many students will not seek resources for fear of this same stigma. Reducing the likelihood that medical students will access these resources is not only dangerous for their well-being in medical school, but presents the concern that a large number of students will enter the profession already burned out and not able to maintain their well-being as they transition to full-time patient care. If we want to ensure that the future of medicine in Colorado is well prepared to take on whatever challenges they may face, we must value their mental health by encouraging them to do the same without any hesitation. Thank you again for the opportunity to speak and for holding this meeting today.
Thank you. Really appreciate your comments and appreciate you taking the time to come down here. It looks like Dr. Borstead has his hand up again. You're unmuted. Dr. Borstead?
Thank you. I apologize. No, I apologize.
Okay. No worries. Okay, who else do we have, Paula?
I'm not seeing any other hands, so you might want to read some more comments.
Okay. That's what I'm gonna do. Okay, so we have a comment from Michelle Georges. I have presented at the American Psychiatric Association meeting in 2018 and 2019 on the topic of physicians with mental health problems, including addictive problems. Dr. Doris Gunderson was one of the presenters in 2019 and talked about the program. Most attendees were quite impressed with the program and lamented the state of affairs in their state or country. We are seen as a model for other physician help programs. I would support the current contract. Okay. And I think making sure right now that I want to make sure that we're all on the same page is today we're talking about the policy, and I understand that obviously there are concerns about the contract, but that's a separate issue that's being handled through the procurement process. There's actually a separate subcommittee of the board that's looking at that. And so today we really want to focus on the confidentiality piece so that the board can reduce this to writing. They can memorialize the confidentiality program in writing so that it doesn't matter whatever happens with the procurement process. The confidentiality piece would have to be followed by whoever was the peer assistant, the board's designated peer assistance provider. And I hear a lot of people that still, we talked about the current state, and I feel like there's a lot of fear out there from people. And, I can't speak for the board. And I think when you want to hear what the board thinks, you can listen into those public meetings and hear their thoughts. But what I can tell you is I've not heard anything from them that is trying to do away with the confidential treatment. That is, as I said, that has been sort of the mainstay of the board's thinking since peer assistant providers were put into place. And, I can tell you that the board's thinking has been historically, and you've heard from a couple of board members who have been off for many, many years, but that the thinking has always been the recognition of the importance of early intervention for licensee health conditions, and to do that in a confidential way because it has a positive impact on patient safety. So as the board is relooking at this, we're really just looking at what would be the parameters of that program and what do you think those should be? What do you think, what would you like to see, as far as eligibility or exclusions or compliance? Like what do you want those parameters to be when they define this program? How do you want to see it? And I think that's going to be really helpful to the board. We have another comment from Lisa Taupe, and I apologize if I'm saying your name wrong. Thanks to the speaker who so generously told his story of success using the program. This is so heartening and speaks to the value of the program. And thank you, Lisa. I wholeheartedly agree. I think those stories are really impactful. And then I'm going to zoom up here because it looks like Dr. Eugene Sherman would like to speak. And I am unmuting your line. Dr. Sherman, you're unmuted on our end? Yes.
Can you hear me?
Yes.
Yes, my name is Dr. Eugene Sherman. I am now retired. I was an interventional cardiologist in Aurora and Centennial for 41 years. I served approximately 3 decades on the Credentials Committee of under various names, but at the Medical Center of Aurora at 2 campuses. I have many stories about the importance of confidentiality, but to speak to you and to exclusions, I have found the program worked very well. I cannot tell you how many physicians' lives, families, and careers we were able to save because we offered them confidential early intervention when we saw problems with mental illness, with drug dependency, and other related issues. in an era where we're starting to see problems with our workforce in terms of size and burnout, this is critical to maintain our workforce in Colorado, that we have confidentiality. To your question about what exclusions, I think those of us who have experience with this, we need to see what you want to offer in terms of exclusions or what you think refinements are. I can't offer you anything. I don't see any problem currently with the system. I would urge you to refine the system by working with providers such as CPHP, with other services and medical schools and organizations around the country. But I think our program has worked very well. I'll just close by telling you a brief story. Right after I was chief of staff, the chief of staff got a report that drugs were missing in an anesthesia setting. And when the anesthesiologist was confronted, he said to the chief of staff and the hospital administrator, "Can I call my wife? I want help." They didn't know if he would ever come back. He made his phone call to his wife. Then he came back and said, "I want help." I dealt with that anesthesiologist doing cardioversions for many years. Every time I saw that we had saved his career, I wanted to give him a hug. We saved this gentleman's career. We saved his family. We possibly saved his life. This confidentiality and the way it's worked in Colorado has been outstanding, and it is a national program. So if you're going to make refinements, let us see what the suggestions are. I urge you to seek counsel from other experts in the area, and we'll all work together on making the refinements in the program. Thank you.
Thank you. Appreciate that, Dr. Sherman. Paula, who's next?
Ned Clutch, or Dr. Clunge.
Okay. Dr. Clunge, you're unmuted.
Yes, thanks, Karen, for the clarification. And I try to speak to these by saying I like what you have in place now, but I could be specific. I think as far as eligibility, we are talking about all licensees, including medical students and residents. I'm not quite sure how an applicant self-referral prior to application would work. So I'm not exactly sure that, and they're not licensees. So I wasn't thinking specifically about that. And as the board thinks about that, I'm sure they have ideas. I think the idea about voluntary confidential treatment is a requirement, because if you're asked to go there, then it's no longer voluntary, and it's raised to a level where the clinician is not making his or her decision. The next one I wrestled with, should the request be prior to impact on practice? I think prior to impact on practice that results in a complaint to the board, yes. Whether or not there might be some approach where he said, has this impacted your practice that did not raise to a level of complaint? I just am not quite sure how that would work. So I think I would say prior to reported impact on practice. And I think an area to explore for the board is, what about kind of if a hospital board prior to this kind of area of saying we're taking action, suggested strongly or made a physician, quote, voluntarily report or voluntarily seek treatment. I think that is a different category. I think it'd be hard to figure out how to make that work, but I think that's not quite voluntary. I think the exclusions, as you put forward, are exactly right in the current approach. I think compliance must be required, because if you're not being compliant, then the threat of potential impact on practice and safe practice and substandard medical care becomes really important. But how defining that, here's where I think, honestly, you want to make sure you pick a contractor who has the ability to make those decisions. Because if we set up, I mean, we can say, well, you didn't show up for treatment, you didn't get your blood test. Those are all really clear. I also think that the professionals who provide confidential treatment recognize when someone has moved out of that compliance issue. And so I think you want to make sure that you allow for the knowledge and expertise of the contractor to say, you are no longer compliant, we're going to report you, along with the hard measures that I think you've already talked about. I think when a clinician becomes non-compliant, they need to be reported to the board. And I think the issue about saying, if you're non-compliant, that voids confidentiality is something that we have to tell participants before folks come. So those are more specific to the questions you asked.
Thank you, Dr. Kahlon. Dr. Borgstead, your hand is raised again. Would you like to speak? I'm unmuting your line.
Thank you very much. I would just like to reiterate one other comment, and that is that in reference to what Dr. Kahlon just said, it's really key that whoever the peer assistance provider is, that they have the expertise of psychiatrists and physician experts in that regard. And my concern is that the way I understand the potential for the change in peer assistance providers, that board has no physician, that organization has no physicians on its board. I think whatever organization you pick, you need to have someone with physician expertise.
Thank you, Dr. Borgstead. Dr. Aguilar, I'm going to call on Dr. Aguilar. Your line is unmuted, but it looks like you're self-muted. There you are.
Thank you, Karen, and thank you for holding this meeting. I think that, first of all, I think that what's difficult in listening to this discussion is that there was concern by people with legal expertise that the new RFP did not guarantee the same confidentiality that existed in the prior contract. Because I am not an attorney, I would have to look at my notes and even then not really personally understand what the difference was. But I think that because that has raised a letter of concern, sorry, being a board member, that has raised a level of concern among physician providers, there's a certain amount of trust that has been lost in this process. And so I appreciate the earlier physician's comment saying, I think what's really most important is to see what the actual language is and what the legal interpretation of that language is on the part of people whose trust is still maintained by physicians. And by that, I mean people like COPIC and the Colorado Medical Society. Unfortunately, back when I was on the medical board, the selected provider was the provider for nurses, and it was well known that the nurses had no confidentiality and that nurses would not voluntarily go to seek treatment. And at the end of the day, that's what we want to ensure here, is that we have a level of trust in the provider that will lead to our medical providers continuing to seek voluntary treatment at a high level and not having their confidentiality broken. And again, unfortunately, until there's language written that people who I think physicians feel are looking out for their privacy has reviewed and agree maintains the level of confidentiality they've experienced up until now, it will be difficult to opine on whether what's stated is sufficient or not. And then finally, I do want to unfortunately concur with Dr. Borgstad's statement. Physicians, I think, do tend to, they don't actually trust other colleagues of theirs, and I don't think that they would trust people who are not also physicians. And so whoever the provider is, I hope that they could provide that level of care for our physicians. Thank you.
Thank you, Dr. Aguilar. Paul, I'm going to do a couple of comments here, and then we'll go back to calling on members. So we have Suzanne Hamilton. Will there be public input into the procurement process? What I will say again is that the board is required to follow the Colorado Procurement Code. You can look at the board calendar. The procurement committee met, I believe it was last week. Being home all the time, kind of the days all run together, but that was a public meeting and people dialed in to listen. And so that response will also answer something from Dr. Tyler Anstead when he talks about transparency. He talks about transparency in the decision-making process for the contract evaluations. So again, because the board is required to meet publicly, when they meet for these sessions, it is a publicly noticed meeting. So I would encourage you all to watch the board's website to look at that. Dr. Borgstad said, are there any CMB members on the webinar? I do not see them on my list of attendees. I don't want to say no because it's a very long list. But what I can tell you and what I had said at the beginning is that this webinar is recorded. The members of the committee will be provided with this webinar, which is why I'm reading the comments into the record, making sure that the people on the policy subcommittee, as well as the full board, hear all of these comments. I wanted to go back and finish Dr. Tyler Ansted's comments. He said, minimum requirements for policy. Confidentiality, not requiring providers to sign a waiver releasing information to the board. 2, doctoral level expertise in treating mental illness and substance abuse. And then I already talked about his transparency comment. Robert Alsever, it looks like his comments, and again, I apologize, my screen, it's just super tiny. Minimum requirement, I'm sorry that I cannot connect my mic. And this is Robert Alsever. Very nice job on summarizing the questions of the board. I am the prior Vice President of Medical Affairs at SMC Parkview Medical Center and Centura Health. I practiced endocrinology for 35 years. I have had extensive interaction with CPHP as well as being on the board for 8 years at CPAP. I have not heard input for CPHP. I believe that any record and involvement of board will decrease any provider from voluntarily any involvement of the board will decrease any provider from voluntary self-referral to CPHP. I have been able to get many physicians to go because it does not involve the board. CPHP has always involved the board if they feel there is an issue with patient safety. I am in favor of any involvement of the board and review of physicians. Assuring that the board is not involved has been key to involving them in self-referral. Okay. And Jean Martin from COPIC. Karen mentioned that the board wants to define the parameters around confidentiality, but the survey questions have led our policy holders to believe the board intends to limit when confidentiality applies. That appears to be the main area of confusion and why we want to see the draft policy to weigh in for clarity. Jean, and again, I'm going to get to that, but I guess maybe I should just forward my slide and get to that now. This is the next steps are as follows. All of this feedback will go to the subcommittee and the full board. The policy subcommittee meets on February the 11th to start drafting the policy. They will make the policy recommendation to the full board on February 18th. Once the board agrees on a proposed policy, stakeholders will be re-engaged to provide feedback on the draft policy. So those are the steps after today. We are asking for your thoughts now so that the board can be very thoughtful when they draft the policy, so that the subcommittee can be very thoughtful as they draft a policy to give to the full board to consider and approve as a proposed policy, at which point we will take that proposed policy, that written document, we will distribute to all of the stakeholders that I talked about earlier, the 33,000 licensees, all of the medical board stakeholders and partners, so that then we can regroup together and talk about the document and what changes you all would like to see based on the written policy. So that's where we're going. That's where we're going after today. But again, just trying to make sure that we get some of this really good feedback before the board puts pen to paper, because it's always helpful to know what you're thinking before we start, so that when we give you a product to look at, it reflects your thinking. Christy Powell-Mormon supports physician assistants participating in the program. They currently do, and she supports their continued participation. I have an anonymous comment that says they're asking that their name not be included. I would support extending and codifying as much confidentiality as possible to providers, as the consequences of public reporting can be devastating. The lack of confidentiality or limiting confidentiality would deter self-reporting. I would not require compliance for self-reporting providers. If compliance is required, why would anyone self-report in the first place if they will be required to comply with a yet to be determined treatment? No one in their right mind would seek consultation. In addition, I would express strong support in seeking a new company to replace CPHP. As a state, we need a program that is focused on the providers seeking help rather than a program that seeks to justify itself by maintaining an irrational stranglehold on self-reporting providers for mental health issues. And then, let's see, I have two more here, and then we'll go back to raised hands. Many of those, this is from Robert Alsever. Many of those referrals by the, many of those referrals have had successful outcomes. It is offered as an alternative to an adverse action if done by the hospital before they have taken action. It is not a requirement, but if they don't do anything, it will become adverse. Sometimes we'll also ask them to refer themselves to CPEP. Ned has a good point, and the hospital needs to involve legal help. Okay, Paula, who's next?
So we have Lynn Perry.
Okay, Dr. Perry, your line is unmuted.
Thank you, and thank you very much for listening to all of us. I feel a little bad coming after such notable people as Dr. Kalange and Senator Dr. Aguilar, who have very crisply identified the issues. I'm representing the Colorado Medical Society, who overwhelmingly, all of whose members, we sent out a, we did send out a survey and got back lots of support. Not a survey, but a letter, support for confidentiality. As a professional society, this is ultimately about patient safety and about our patients. You've heard a lot of comments about saving physicians, but what this is ultimately about is getting physicians treated. Physicians already are held to a higher standard when they start medical school and take on the role of being a physician. We already have an unbelievable amount of oversight from the public And it is a perceptual concern that confidentiality will be restricted. You've heard of, I think that what you have heard overwhelmingly is that we have a system that works extremely well when you have when you are working with a peer assistance program that can make the kinds of judgments you're looking for on their own. When they have the example that Dr. Sherman brought up is one of those that if you over describe what who is exempt, that anesthesiologist probably would not have been exempt because the hospital identified a problem. But in that instance, somebody who wants to seek help and is not reported is going to be a better physician and is going to be able to take care of more patients safely. I think it's very important when you decide to refine your policy that you do not refine it so that there is no wiggle room, that there is no ability to be nuanced. There's no question that there are physicians who never develop insight and ultimately will be non-compliant and be reported to the board. And that's fine. I was on the board. I understand that there are outliers like that. But for the majority of physicians whose primary goal is to take good care of their patients, it's absolutely essential that we have a program that does not have either the perception that all of their confidentiality will be not protected, and that they have a place that they can go to seek help that is safe and trustworthy. Thank you very much. Don't fix what is not broken.
Thank you, Dr. Perry. I'm going to unmute your line, Christopher Schneck. I apologize if I butchered your name.
Hi, this is Dr. Schneck. Can you hear me?
Okay. Go ahead.
Can you, yeah. So I'm Dr. Schneck. I'm an associate professor of psychiatry at the University of Colorado. I'm also the medical director of the Helen and Arthur E. Johnson Depression Center and the behavioral health director of the UCH HIV clinic. And I am formerly the past president of the Colorado Psychiatric Society. And I'd like to say I'm also in favor of crafting a policy that matches the current approach to confidentiality. As somebody who refers to the Colorado Physician Health Program, and also I treat patients referred to me from CPHP, I clearly recognize that the need for confidentiality is really absolute, and I've seen firsthand the reluctance of physicians for entering into treatment when there are any concerns about what they're telling me may not be absolutely confidential. Regarding the exclusionary criteria, I think that the current exclusionary criteria are quite reasonable. And as to your question about compliance, I'd support what Dr. Kalan said regarding relying on the expertise of the peer assistance program to determine what constitutes non-compliance with treatment. And if that does take place, then they make the decision to report to the medical board. And finally, as to your question, how does this ensure patient safety? I think continuing the current policies as they exist helps eliminate barriers for physicians to enter into treatment programs so that they can really be at their healthiest to deliver care to their patients. So I very much appreciate you all holding this hearing, and thanks very much.
Thank you, sir. Connie Price, it looks like your hand was up. I've unmuted your line.
Great, thank you. So I just wanted to answer some of the targeted feedback questions. And, you know, regarding the requirement to seek confidential treatment voluntarily, you know, I agree with Dr. Kalanj on this. It would have to, by definition, be voluntarily. It doesn't necessarily mean that the physician or the provider has to be the one to first approach or notice something. But once approached and noticed and acknowledged the problem, as long as they're willing to do it voluntarily, then their confidentiality should be protected. I think if you don't go voluntarily, then there isn't anything to discuss here. It has to be voluntary. As far as compliance with the recommendations, I did hear a previous concern about not knowing what the recommendations would be. However, I think once you are in a position where you are acknowledging the need for help and that you are seeking such help and you're putting yourself at the mercy of a professional, I do think that there needs to be some accountability to the compliance. And it's both for the at the person seeking treatment. I think it also gives them some very clear rules and some boundaries that also I think will aid in their recovery. And it also gives the institution and I think the public some reassurance that there will be some accountability to a treatment plan. So I think there needs to be compliance. Now, does that mean that there, you know, if there's a lapse, if, you know, one of the tox screens is positive, what happens then? It doesn't necessarily mean that's, you know, that they're out and that we can't help them anymore, but it just means we have to be able to monitor, and we have to be able to ensure that they're continuing to progress and be treated. And, you know, in terms of the limitations and how they should be advised, I think it is what ultimately is decided. Of course, the person entering the program should be fully knowledgeable on their rights to confidentiality and what it means, what kinds of things would limit their right to that confidentiality, if any. Thank you.
Thank you. Really appreciate it. Dr. Aguilar, your hand is raised. I'm going to unmute your line. If you wish to speak, I think you just need to unmute your line. Okay, we can come back to you. Dr. Borgstad, I've unmuted your line. Dr. Borgstad, if you want to speak, you just need to unmute your line.
Yeah, I'm sorry. I don't know why it keeps popping up that I'm raising my hand. I don't have anything more to say. I lowered my hand earlier. Sorry.
Okay, no worries. Okay, Paula, do you have anyone else here with their hand raised?
I see Jeremy Lazarus again.
Okay, try that one.
You're unmuted. Jeremy, you're unmuted. And I seen Dr. Epperson earlier, but Dr. Kalange, I'll unmute him.
Okay.
I don't think I raised my hand, so I'm good. Thank you.
Okay.
All righty. Neil Epperson, if you want to speak, I've unmuted your line.
Thank you so much. Again, I also appreciate the opportunity to speak at this hearing. It's such an important topic, and I am speaking actually on behalf of a number of the chairs of various departments of medicine here on the CU Anschutz Medical Campus as they are in the middle of their clinical workday. And as the chair of psychiatry, I was able to clear my schedule a little bit more to be able to speak on their behalf. So if you will bear with me, because I want to represent their words as they have written them to me. And again, I think that many of them would be happy if there's a place where they can just send their comments directly. They'd be also happy to do that. They just wanted to make sure that their words were heard. So on behalf of Dr. Evelina Berger, who is the professor and chair of the Department of Orthopedics, she says, quote, We have used this service referring to CPHP, and again, we're trying to de-emphasize support for any one particular vendor, although a number of people have shared with me that they have enjoyed working with CPHP, but we recognize that the vendor is not as important as issues of confidentiality and peer treatment. So they have used these services over the past year, and it has been a valuable safe haven to protect our colleagues from burnout and suicide. Providers are normal human beings, and the stressors of daily life are exacerbated in medicine, as we do not only deal with our own challenges, but also those of patients we treat, and this becomes overwhelming at times. The referrals in the past have helped with navigating abusive relationships, substance abuse, and various other behavioral problems, which was the manifestations of overwhelmed providers. And she adds that orthopedic surgeons have the highest prevalence of suicide at 28.2% of all surgical fields. Then Nanette Santoro, who is the chair of obstetrics and gynecology, she states, if these referrals, and in capital, do not protect the confidentiality of the physician being referred, I can unequivocally state that none, again capitalized, of the 3 above referrals would have been made. And she is referencing 3 physician faculty that she has referred to CPHP in the past 11 years. The stigma and possible negative downstream consequences to a physician who is publicly outed for a mere referral, which would be for a suspected diagnosis that turns out to be unsupported after the evaluation, is so great that I would not wish to jeopardize the careers of any of the doctors I have referred to date. So thus, even though she's not mandating that these doctors seek these treatments or evaluations, it is something that she would suggest to them. And as Connie Price recently said, and I would concur with her, that just because your chair or your hospital board or a colleague even says, you know, let's talk about this, there's this resource and maybe you would want to consider it. That's how we get people to treatment all the time. There's nothing about that that is mandated, is a recommendation. And yes, the person has to be voluntary, but we consider even a department chair making a recommendation should not be taking away the voluntary nature of the person going. So I also have comments from the chair of internal medicine, David Schwartz, as well as the chair of radiology, many of which bring up these same sort of themes. And so just for the sake of time, I will stop with those 2. And I want to thank you so much for giving us an opportunity to really represent what it's like for leaders when they have faculty that they want to have some treatment or even just suggesting treatment, that they too would not refer somebody if they thought it were to jeopardize that individual's privacy and confidentiality to treatment. Thank you.
Thank you. Really appreciate it. And again, it sounds like you have a lot of written comments there. So just reminding people that we're also accepting written comments, and you can email those to Paula Martinez at paula.martinez@state.co.us. And all of those written comments will be forwarded to the policy subcommittee for their review as they begin work on the policy, and then also to the full board for their review when they consider the recommendation of the policy subcommittee. So I'm going to do a couple comments here. Robert Alsever says, let me correct my previous comment. I am not in favor of any involvement of the board in review of physicians unless referred by a physician health program of some similar to CPEP. Roger Pumphrey says, please keep the critical aspect of confidentiality. The system is working and I support keeping it as is. Not a question, just a comment. Lila Cummings from CHA was listening in for Catherine Mulrady. Christy Powell-Morman says, this may be on the board in CPHP's purview, but one issue with confidentiality may occur when credentialing with insurance companies who ask about substance abuse mental health treatment. Does CPHP have any control over how that is reported? Is the board notified of credentialing answers? By answering questions on mental health substance abuse in the positive when credentialing, I wonder if confidentiality may not stay in place. I think that is a interesting comment, Christy. Something that is certainly beyond my purview, but I will pass that on to the board. Dr. Tyler Anstett says, is there anyone on this call who is not in favor of confidentiality for providers in the peer support process? I would love to hear from them, as a lack of voice on this side would speak volumes and should be provided to the board. Jeremy Lazarus says, if the liaison process is not included in the contract and the expectations on both sides is critical, at the end of the day, a successful program will require trust between physicians, the program, and the medical board. This trust is built over time, and making the confidentiality more granular may impair that trust. If the process has been working, then it can be further placed into a contract. That would be preferable. Dr. Lazarus. Okay, so who do we have next, Paula?
I have Connie Price.
Okay.
Oh, sorry. I think that was from the last time I spoke. I'd never lowered my hand.
No worries. Okay, doesn't look like we have any hands raised. So I want to again go back and talk about, some of these questions. So we've talked a little bit about, sorry, don't want to make you dizzy. We've talked a little bit about, everyone should be eligible. Should there be exclusions? We talked about compliance. What do you think about what should people be told when they seek voluntary treatment? Do you think when they go in to enter into this voluntary confidential treatment, do you think they should be made aware of any of the parameters, like the compliance parameters, if those are set? Do you think that's something they should be told when they start? Do you think that's something they just get told when the report to the board is eventually made, if that happens? How do you think that works? And what are your thoughts on that?
So I do have Dr. Epperson's hand raised.
Okay.
No, I thought I lowered my hand. I'm sorry.
I think what's happening is we lower your hand and you're lowering your hand, which is re-raising your hand. I think we're all crossing each other out. So anybody have thoughts about that? Anybody want to talk about that? We've got, looks like Dr. Borgstead, did you want to make a comment? Your line is unmuted.
Who are you speaking to?
You, Dr. Borgstead, did you have a comment?
Yeah, could you please just restate your question so I can answer it appropriately?
Sure. So when we're talking about if there's a point where the peer assistance provider is going to report a confidential participant to the board, do you think that the person who wants to participate in this program should be notified before they start what those limits are? So for instance, when I go in to sign up, should the peer assistance provider tell me these are the rules of the program, and if you're not compliant or whatever the board decides, then I'm going to have to tell the board about you? So my question is, should they be told before they start the program so they know that before they sign up? Or is that something that you just tell them at the point that you're reporting them?
No, I think that they should be told that in advance. I mean, when they sign up for a peer assistance program, they should understand the metrics of that program. And so if the following happens, we will be required to report you to the medical board. And to amplify just a little bit on that, I think this, one of the subtle nuances that the board needs to be aware of is there's a difference between relapse and non-compliance. If someone has already agreed to a voluntary limitation of their practice or suspension of their practice, and they're compliant with that, and they're of no risk to the patient, therefore, and then they come back and say, I had a relapse of alcohol use, substance abuse, whatever. That's a relapse, but that's not necessarily something that would merit a reporting to the board. But otherwise, yes, I think that it needs to be very clear when somebody comes to CPHP that you would sign an agreement, or when whatever peer assistance program the board is using, that here's the metrics, and if you stay within our guardrails, you'll be okay. But if you don't stay within our guardrails, there's going to be a problem here. We're going to have to report you to the medical board.
Thank you. We appreciate that. And I think that Dr. Borgstad raises a really good issue, and something that I think can be quite, it can be pretty daunting to try to define that, to try to define what is non-compliance, and I think that the science is clear, and the research that relapse isn't necessarily non-compliance, but thinking about at what point does it become non-compliance, and what are your thoughts about that? I mean, I think either of those two questions are things that the board may struggle with as they are working on this policy. And so I think that if you could provide your thoughts on that, maybe that would be helpful. So Paula, do we have anyone?
Yes, we have Lynn Perry.
Yeah, I see what you mean, because I started to unmute myself and ended up just muting myself because everybody was pushing the same button. Thank you. This is Lynn Perry. I think it's important to know that there are other peer assistance programs throughout the states. I've talked to some of them, and they have actually not solved, but they have, to your point, have different kinds of contracts where I would agree that people entering a program voluntarily should be told of the consequences and the parameters. And some programs actually have that as part of their contractual obligation, is to say, this is voluntary except for A, B, or C. When they take in a patient or a provider seeking assistance. I think the important part of that is that confidentiality and when that person who is under treatment becomes non-compliant, or it's no longer an exception or whatever, is within the discretion of the peer assistance program. And I think the concern with a broad, we can notify the just sign here, and there's no confidentiality potentially, is that there is a potential for, or concern, I won't say potential, there is a concern, and it has been a concern, that that could be inappropriately used by somebody outside of the peer assistance program. So I think it's important, and I think that's what you've heard from people, is that judgments and flexibility to determine which and when patients may present a potential risk to patients and therefore are reportable to the board. That should be a decision of the people who know this individual. I don't think the board can make arbitrary lines, because it will vary tremendously within context and individuals and where the person is in their treatment program. So I hope that will be helpful for policy making as the board pursues this. Thank you.
Thank you, Dr. Perry. Paula, while you look for people, I'm going to read a couple of comments here. Christy Powell-Mormon says participants should be told up front about what may compromise confidentiality, such as noncompliance. However, I do think it should be made clear at the beginning that every effort will be made to keep confidentiality. Amanda Kimmel says the current peer assistance provider has every person sign a confidentiality agreement with the limitations of confidentiality at onset, even prior to the intake appointment. Robert Alsiever says, agree with Dr. Borstead about upfront laying out the rules to the applicant for physician health treatment. Great. So who else do we have, Paula?
So I am unmuting Sammy Diab.
Okay.
Yeah, hi, Sammy Diab. I'm president of Colorado Medical Society, but I'm speaking on behalf of myself here. Dr. Perry did a great job, expressing the views and the position of CMS. My question is, during the COVID crisis, when the burnout rate is so high and everybody is so stressed out, providers are working extra time to save lives, is the need for policy granularity critical? Is there any background in terms of public harm that's leading to all this debate and taking extra effort and creating this added anxiety on the providers to do that? I'm just still a little bit unclear on the urgency of addressing this at this point in time.
Okay, thank you. I think we can pass that over to the board. And Paula, do we have anyone else?
Yeah, so we have Dr. Irene Aguilar. I just unmuted you, Dr. Aguilar.
Oh, thank you. I actually was just going to echo Lynn Perry's comment that I don't think you can make a blanket policy, and you have to have the confidence in your peer health provider that they can determine when a provider has been non-compliant and needs to be reported. Thank you.
Thank you.
And I don't see any more hands.
Okay.
Actually, Dr. Epperson, I am unmuting you.
Thank you so much. I'd also like to suggest, because being in medicine, I know how frequently we have turnover in providers, and any vendor that you happen to contract with, I would want to make sure that they have the full complement of expertise to really be able to address the nuances of these issues with the provider, and to be able to not only make a decision themselves, but perhaps, because again, I think anytime you get a service and you have to bring in new providers, their level of expertise or experience in these matters may be somewhat less than what their other comrades are, and as far as the organization with which they work. And I would certainly want, if there was a decision to be made to report somebody to the board for noncompliance, to make this not just the decision of perhaps one clinician, but perhaps this is a group discussion about again, with confidentiality, this is what's happening. Do we all agree that this person should be reported? And not allow it to be sort of on the basis of just one therapist or one psychiatrist making the decision. I just think that is leading to an opportunity for people with less experience, maybe less expertise in a particular area, making a knee-jerk reaction about a particular case that could have incredibly detrimental effects on that individual's professional career. Thank you.
Thank you. I think maybe a follow-up question, and just again to see what you all think about this. I know that we talked about that 70 state board survey, and I know that in some states, you know, that the confidential program is there's a little more collaboration with the board while maintaining the confidentiality, which is very similar to the liaison program that I discussed here. But is it something that maybe if there's questions about whether or not the report has to happen, is that something that that could be discussed with a member of the liaison committee, in a de-identified manner. So, asking the medical board representative, does this have to be reported? Is that something that people have a thought about or have any reaction to?
Dr. Epperson?
Okay.
In reaction to what you're saying, unfortunately, I don't know what the current process has been. I'm just concerned about new vendors perhaps not having had sort of the relationships with this particular state, with people who are getting referred. For example, my colleagues and I who have to sometimes say, hey, I think that this person would benefit from the services, those kinds of things. So I don't know what the process currently is. I just don't think that whatever we put forth and is decided upon, that it shouldn't be on the basis of just one person making that decision. So if there is an internal to the organization kind of discussion, we have, for example, a lot of discussions here as a faculty when we have something that we're concerned about. Perhaps that would be a way to do it, that it have to be sort of an internal discussion, or if the liaison from the board could be engaged, like you say, in a very confidential fashion, de-identified fashion, that might also work. I just want that piece in there so that reporting to the board is not a one clinician decision.
Okay.
Thank you.
Great, thank you. Okay, so what else? Do we have anybody else with their hand raised?
Not at this time.
As I know, we've had a lot of people speak out, and a lot of you work in medical, as chief medical officers or with residents and things like that. And so one question I think that has come up before is, are there concerns that, when you think about public board actions, kind of the hallmark of that is that it's a public action, and so everyone knows, where the clinician is. So if a clinician is on an interim cessation of practice agreement, or if they're suspended, people can see that in the National Practitioner Data Bank, and so they don't hire them, or they're not, allowing them to work at their facility. And so, do you have any concerns? Anybody who's on the call, and assuming we have some consumer members as well, does anyone have any concerns that in confidential treatment there's not that fail-safe, that if somebody signs a non-compliance agreement, or if somebody signs a non-practice agreement but it's private and confidential, that they could go work somewhere else? And what are your thoughts on that? Looking to see if we have any hands raised. We do. We have Connie Price. I've unmuted your line.
Great. Hi, it's Connie Price again. So the reporting, I have to look up the exact language, but you do have a time period during an investigation that you can work through some issues. The only time I think the reporting really is relevant is if their privileges are revoked during the investigation, and or if they leave during the investigation. So it really behooves, and the system actually encourages the physician to stay on and complete their therapy during the process of investigation, because if they were to leave, it would definitely be reported. If they were to resolve it and what would be reported is either nothing, depending on the situation and the timing, or a report with a defined resolution that accompanies it. So I think the incentive really is for the practitioner to stay on and complete the treatment, because if they leave, it is a definite report.
Okay. Thank you. That's helpful. I appreciate that perspective. Who else? I don't see any more hands. I'm going to look at my question box here to see if I have anybody who's typed in recently. We have Lisa Tope, and again, I apologize if I'm mispronouncing your name. I like keeping the policies and aspects of the program, especially confidentiality, as they are currently working. The expertise of the treatment provider has to be ensured as well. I agree that there should be a committee to determine whether noncompliance exists. I also think the treatment provider may be concerned about liability if they don't report if there is a question about it. We then have a comment from Edmund Casper. Thank you for holding this forum. It has been very helpful. Assuring competence of providers is the primary issue. I share this as founder and past president of CPHP. Thank you. Adam Ward says, in regards to your question on collaboration with the board while maintaining confidentiality, I would say only if the provider health program thought speaking to the board in a de-identified manner would be helpful. However, I would prefer that the PHP had the expertise and confidence to know themselves when the board should be notified about a referred provider. And Dr. Borgstead says, NPA currently works well, not perfect, but extremely well. Happy to comment if you would unmute me. So Paula, can you unmute Dr. Borgstead?
Yes, I'm working on it, Therese. You are unmuted on our side, Dr. Borgstead.
Thank you. Can you hear me okay?
Yes.
Yeah, so I'd like to return to one of Karen's comments and also comment on the non-practice agreement. And I can also comment from the perspective of having been the chair of CPHP after my tenure on the board. So I've looked at this from both sides. And I think the current non-practice agreement works out pretty well. And if there were a change and practitioners who were ill in some fashion, broadly defining that word, knew that the licensing board would become aware of their status if they needed to seek practice while seeking treatment. The problem is they wouldn't seek the help to begin with. I think that the non-practice agreement and the current liaison committee approach where you have, I believe it's 3 board members and 3 CPHP, the current provider members, meet and look confidentially at cases. And then if we see that there is truly non-compliance with the non-practice agreement, they get reported to the board. Works pretty well. And I think that fits in with those 65 boards. But I want to be careful that I think we should adhere to the situation that we've got right now. My feeling is if it's not broken, don't fix it. And it hasn't been made clear to me, what's broken that we're trying to fix.
Okay, thank you. I appreciate that, Dr. Borgstead. Anybody else? And I know like everyone's tired. We have 10 minutes left, but I really want to make sure that everybody's had an opportunity to put in their, I like to call their 2 cents. I want to make sure that we're getting all this information to the committee and to the board so that we can make sure and have, again, so they can have all the information. There's no thought or comment or suggestion that's too small, that's you know, really just anything that's on your mind, making sure that we get that to the board is really going to make sure that we have, that when we come back to you, we have a policy that reflects your thinking. So please, if you have something to say, raise your hand. Okay, we have Stephen Thorson. Stephen Thorson, I don't see that you're connected to audio, but if you can send your comment in through the questions or chat box, I can read it for you. It doesn't, I don't see that. Go ahead.
Dr. Borgstad's hands raised again.
Okay.
No, sorry, we're conflicting with raising and lowering. My apologies.
No worries.
I promise I'm not touching your hand.
Yeah, in this new world, we just go with the flow here. Okay, I don't see anybody else with their hand raised, and so I will go ahead and move on to the next slide to wrap up. I don't have any more chats in my box. And again, we're at 1:50. So, and I had moved here a little bit earlier to answer some questions in the box. But essentially, you know, where do we go from here? What are the next steps? And what those next steps are is that when we hold these types of webinars, when we gather stakeholder comments and thoughts for the board, it's recorded. We take that recording and we put it on our website so people who couldn't make the meeting, they can listen in. And maybe you'll go back and listen, and then you will think that of things that you didn't say today. And just remember, you can come back on Tuesday and join that group. And maybe you just want to listen in, or maybe you think of something that you wanted to say. You can always also submit your comments in writing to Paula at Paula, Paula .Martinez, MARTINEZ at state.co.us. And we'd like to have all those in by February 9th so we can get those to the policy committee. The subcommittee, they meet on February the 11th. If you look at our website, at our calendar, you will see the link and you can join in and listen to the policy subcommittee talk about this, and you can hear what their thoughts are and you know, watch them, listen to them draft the policy. And when you're talking about transparency, like, that's the best way to know what the board's thinking is on these things. Once the policy subcommittee meets on the 11th, they'll take their work and their recommendations to the full board at its February 18th meeting. Again, everybody on this call, and I know that we have partners who've been doing this for years, but for anybody who's on this call who's not familiar with this, you go to the board's website and click on the calendar, and you can see every time the board meets, and there'll be a link for you to listen in. So February 18th, the full board meets. That's when the policy subcommittee will make its recommendation to the full board. Now, I don't know what the full board will do with the recommendation. You know, they may want the policy subcommittee to go back and do more work, or they may agree with what's been presented. But once they agree on a proposed policy, then we will reach back out to all of you through the web blast. We will have more meetings like this where we'll go over the written document so you can provide your feedback on the document as written, and we can take that feedback back to the policy subcommittee and the board so they can finalize a policy that everybody's had the opportunity to weigh in on. So with that, Do we have any other questions about how, what it's going to look like moving forward? Anything I can answer about that topic? Okay, I don't see any hands raised. I'm going to take one more peek at the question box. Okay, we do have something from Steve Thorson. The current mechanism for reporting a voluntary participant to the Board of Medicine requires an evaluation and approval of the CPHP Executive Committee, all of whom are physicians. Okay, thank you, Stephen Thorson. So I don't see anything else, so we'll go ahead and wrap up. I want to really thank all of you. I really appreciate your participation. I appreciate your thoughtfulness. I appreciate you digging into these issues and providing, all of this good information for the board. And again, as far as, there are a couple of comments that the survey seemed confusing. I think if people find the question confusing, they don't have to answer that question. They can write it in the text. They can submit their written comments to Paula, or they can attend the next session. The survey wasn't meant to confuse anyone. It was meant to put out some of these same questions for people who feel better participating by a survey. There are a lot of people who they just don't feel comfortable identifying themselves. They don't feel comfortable in these types of meetings. And we wanted to make sure, when you think about 33,000 licensees who are affected by this, we want to make sure everyone had a medium that allowed them to participate in a way they felt most comfortable. So with that, I thank you for your time. Everyone have a fantastic afternoon and a really good weekend. We're signing off. Bye-bye.